I'm going to try to answer the question that was suggested by CJ. Is always foveal sparing ILM peeling necessary in eyes with myopic traction maculopathy? So we will later on, after this small presentation, can debate about all these topics. So these are my financial disclosures, none of them related to this talk. So we know that myopic traction maculopathy is a common finding in highly myopic eyes with an axial length greater than 30 millimeters and a posterior staphyloma. Although there are several mechanisms involved in the pathogenesis of this disease, rigidity of the ILM is one of the most common findings. So vitrectomy with ILM peeling has shown to be beneficial for myopic traction maculopathy, achieving good anatomical and functional outcomes, reducing postoperative tractional retinal detachment, and reducing recurrences. We also know that gas tamponade achieves a quicker myopic traction maculopathy resolution and better visual acuity. So for low-risk eyes, the combination of ILM peeling and gas tamponade is probably the best treatment option. And low-risk eyes include eyes with macular esquisses, such as this one. You can see the pre- and the post-operative findings. Macular esquisses with inner lamellar macular holes, such as this case. Macular esquisses and foveal detachment, and macular esquisses with mild outer lamellar macular holes. But what about high-risk eyes? That is those with a severe outer lamellar macular hole with a very thin retina. There are two factors that may increase the risk of developing a post-operative macular hole in these high-risk eyes, and these are ILM peeling and gas tamponade. So the risk of developing a macular hole after surgery when we perform ILM peeling in these high-risk eyes ranges between 0 and 30%. To decrease this complication, Simada and Ho propose a surgical technique that preserves the ILM of the fovea. So in their reports with the foveal sparing ILM peeling technique, the risk of post-operative macular hole decreased from 16.7 and 28.6% to 0%. This technique has gained popularity, but it's not free of complications. So the first one is post-operative macular hole formation, ranging from 5.6 to 9.7%. And one of the most important risk factors for the development of these complications is the presence of a preoperative outer lamellar macular hole. The second potential complication is the development of a central isolated epiretinal membrane in the area where the ILM was not peeled, and this occurs in 10% of the eyes, causing severe foveal distortion and visual deterioration. Postoperative contraction of the remaining ILM has been reported in as high as 60% of eyes at 3 months, and the recommendation to decrease this complication is to reduce the size of the ILM preserve as the area of the fovea. So recently, a new technique has been suggested to decrease even more the risk of macular hole formation after surgery, and this is the foveal sparing ILM peeling with inverted ILM flap. In this technique, the ILM is peeled off with a centrally preserved pattern, and then an extra superior ILM is prepared for the inverted flap. With the ILM flap cover at the fovea may play a protective role in eyes with extremely thin foveas. In fact, in the reports by Lin and Feng, on 66 and 101 eyes respectively, the risk of post-operative macular hole in this high-risk eye decreased from 9.6% and 17.1% to 0% when the combined procedure was performed, although there were no significant differences in terms of anatomical or functional outcomes. So the second factor that may increase the risk of developing full-thickness macular hole after surgery in these high-risk eyes is gas tamponade. We haven't used gas for the last 15 years in these high-risk eyes, and this was the last case I operated with gas. This was the preoperative appearance and post-operative appearance. I didn't realize that there was a hole during the procedure, but there was a hole after surgery. The pressure exerted by gas on this very thin retina when we place the patient in a prone position after surgery may play a role in the development of this complication. So from my perspective, but we can debate later on, it is reasonable to use air or gas when foveal sparing ILM peeling in combination with an inverted flap is performed in order to keep the flap in the right position. However, is air or gas necessary when we perform ILM peeling in these eyes or foveal sparing ILM peeling? As I mentioned, we haven't used gas for the last 15 years, but we've been using silicone oil. Even though the surface tension of silicone oil is smaller, as long as it is in the vitreous cavity, it has the ability to provide a sustainable force. In fact, in the study by Deng and co-workers, the mean time for myopic traction maculopathy removal was shorter in eyes with silicone oil than eyes with air. So this is an example of the resolution of high-risk myopic traction maculopathy with a severe outer lamellar hole under silicone oil, with improvement in vision from counting fingers to 20/70. Another example of a patient with a severe macular esquisses and an outer lamellar hole, and the resolution of the condition under silicone oil. And we have another possibility, that is to peel the ILM. In these high-risk eyes, I prefer foveal sparing ILM peeling, but to peel the ILM and no tamponade. And this is an example, a case with a foveal detachment, severe outer lamellar hole, very thin retina, severe macular esquisses, and the progressive resolution of the condition. And another example, exactly the same. Here you can see a patient how the outer lamellar hole and the macular esquisses resolve without tamponade. So in summary, and just to start the discussion, in less severe myopic traction maculopathy cases, foveal sparing ILM peeling may not be necessary. In high-risk eyes, foveal sparing ILM peeling with or without inverted flap may reduce the risk of macular hole development. However, there is no consensus about the need of tamponade and the type of tamponade. So thank you very much. And now I think it's great if we can discuss a little bit more. So, for example, for low-risk eyes, those with inner macular esquisses alone, macular esquisses with an inner lamellar macular hole, macular esquisses with a small foveal detachment, or macular esquisses with a mild outer lamellar macular hole still with a thick retina, which is your preferred technique? What do? Do you peel the ILM? Did you perform foveal sparing ILM peeling? Do you use gas? Do you use air? Do you use silicone oil? What do you do? Any of you?
What about just doing posterior vitreous detachment? Sometimes that will be enough to resolve the foveal schisis. That's even less to get more.
Yeah, the only problem is that in many of these eyes, the ILM is very, very tough. The rigidity of the ILM is very high. So I think that removal of the ILM in any way, just peeling it completely or with a foveal sparing technique is very important in order to facilitate the resolution of the esquisses and the defects of the retina.
I agree, it depends on the ILM, if it seems to be very tractional. But sometimes you have a foveal schisis which is not so tractional. You believe it's only the vitreous actually which is pulling. In these cases, I always try to do posterior detachment.
This is one option. In our experience, it wasn't enough in most of the cases. But just any other options, Higi, what do you think?
I think the idea of ILM sparing peeling is that during surgery, if the foveal, the retina, the rest of the retina is very thin, that during the procedure, you induce the tear. Not after the surgery. So therefore, it might make sense to just leave it there. That actually was the idea of the foveal sparing peeling, not the postoperative development. If you succeed in removing the ILM during surgery, very gently to remove it also with the foveal, I absolutely agree. This is what I do as well.
So do you do differently if there is a very thin retina in these high-risk eyes, or if there is just these low-risk cases that I presented at the beginning?
For the low-risk cases, you can do the ILM peeling and you definitely feel more comfortable.
Yeah. So all the panel agreed that ILM peeling and gas will be enough for low-risk eyes?
Yeah, it's enough, definitely.
Or air?
Yeah. Marta, me personally, I'm using the intraoperative OCT on a regular basis. And what I usually do is to observe the intraoperative finding very carefully. And usually I try to perform the ILM peel, but because especially in those cases, the ILM is very has a broad spectrum of consistency. In some cases, I try to, when trying to initiate the ILM peel, it depends on what I observe in the IOCT during the surgery. So,
Okay.
If I decide that the risk is too high to perform, to continue with the peel, I usually don't perform it anymore.
So Roxanne, any other comment?
I mean, I don't have access to interruptive OCT, and so I would say in the mild to moderate cases, I actually do tend to do foveal sparing ILM peel and gas. And in my mind, this is my protection. I don't quite know what I've done to the macula interruptively, so putting fovea sparing, avoiding traction on the macula and putting gas in, I find reassuring. I tend to defer to that. Yeah.
That's good. So let's go to the second cases, those with really very thin retinas, high-risk eyes. In these eyes, two things. Do you peel the ILM? Which technique do you use? Second, do you use any tamponade? Which one is it?
So I would do fovea sparing ILM peel, and this is an education to me, because if you asked me 20 minutes ago, I would say I would put gas in. But I hear what you're saying, and these cases don't come along so often for me to have experienced the full thickness macular hole outcome. Mm-hmm. But I take your point on board, and I would definitely consider silicone oil in the future.
I think this was my lesson learned as well, but usually I've never done silicone oil. And now seeing your cases, I think the only disadvantage the patient has, if it just gets a little bit air, it will take him a little bit longer for the recovery. But it does not need a second surgery. So why does it make sense to do silicone oil at all?
Yeah, that's why in the last cases I use no tamponade, because I think that maybe we don't need anything else, just ILM peeling. In these cases, I agree that foveal sparing ILM peeling is the best choice. So foveal sparing ILM peeling and no tamponade will be my recommendation today, although it takes a little bit longer, the resolution of the outer retinal defects, than when you use, for example, silicone oil. But I think it's better not to reoperate these eyes to remove the silicone oil.
Thank you so much.
Thank you.
Great. So last but not least, Carl